So I'm a medical oncologist. I'm trained in this institute, so it is a great honor to be back here. And there's so many people here whom I look forward to. Yeah, this is the one. Dr. Shukla sir is there. Dr. Rath sir is there. Dr. Dev sir is there. Dr. Lalit sir. They are my teachers. So it's a great privilege to be in front of them. I agree with what Dev sir said that we do see a different kind of a population, but I think we have started to see actually a very different kind of a population in the practice where I work, and I find a lot more of them are resembling the Western community. So there is a lot of heterogeneity in the practice population also. Dr. Gaurav is sitting right in front. I'm sure you see a lot of T4, T3 disease, and the values of gene expression is pretty limited in that kind of analysis. We would agree with that. But anyway, so this is a great science. We'll talk about what is how has the prognostic genomic assays evolved and what it is. So there is a very clear-cut observation for which we have no doubt about. We overtreat. I am talking as a medical oncologist. We overtreat the patients with stage 1 and stage 2 breast cancer. There is no question about it. The only problem is how do we identify? We have been using anatomical features like grade, that is pathology, but grade, tumor stage, tumor size, node, but they are not enough. We'll come to that. For example, this is the large data set from Dr. Chia, who is from British Columbia. In their large population set, about 1,000 patients who did not have systemic therapy, and they were small size tumor T1, T2 node negative. That is the earliest possible stage. The problem is, despite that fact, a lot of patients relapse even if they are ER positive. A lot of patients relapse even if they are grade 1, and obviously grade is a uniformly recognized thing. So the problem is we are not able to identify based on available characteristics sufficiently to avoid chemotherapy and systemic treatment to a large number of populations. So that's the problem. We understand that we are over-treating, but we are not very sure whom should we not treating. So that is how this kind of analysis came into picture. So there are a wide variety of multi-gene assays available. These are enumerated for your use. And there is another one, the fifth one, which is called as breast cancer indexed, or B. And they attempt to identify or stratify the patient into high, intermediate, low risk, or high risk and low risk, trying to tell you that who are the patients who are essentially to treat and who are the patients essentially not to treat. So possibly giving a more precise treatment to the breast cancer population. So the two factors which they said is it should have good predictive discrimination and should have good prospective data. Any data set which does not have a good prospective data set could be only considered hypothetical. So these are the variety of tests which are available, and you could see they are based on n number of genes. Mammaprint perhaps represent the, okay, it's not coming here. I thought it's coming here. And it's not coming here also. Yeah, it's coming. Can it be seen? No. Anyway, so Mammaprint over here is perhaps the biggest gene assay in the sense it analyzes 70 genes. That's a large number of genes, but they are not the same genes. It's not that Oncotype DX and EndoPredict and blah 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 are all testing similar gene. They also have varieties of platform to test, from PCR to nanostring. Some can be done only in US, some can possibly done in any other place. So that's a problem. Also the genes which are common, as you can see, I can actually show here but not here, but you could see that there are very few genes which are common. So they are testing a different gene and trying to come with different answers, and this is one of the problem with the gene test also. So let's discuss the oldest and the most popular, which is called as Oncotype DX. It was till this time available only as a retrospective analysis of a prospective trial, which is not the best way of analyzing. So I think there are only two large data sets of whatever value of this test, of which not all the data has yet been released. One is the TAILOR-X trial and one is the Plan B trial. In the TAILOR-X trial, which is still ongoing and the whole data set is yet not available, they tried to find out that the patients who are in arm A, very low risk patient, can you avoid chemotherapy altogether? And suffice to say that If you have a patient who has a small sized tumor, who has a node negative disease, has a grade 1, grade 2 kind of a tumor, has possibly a low KS67, also has a low recurrence score. And therefore, you could actually ask me and say, why do a recurrence score? Because you can possibly identify this patient anyway. But these set of patients have got excellent long-term results. These are 5-year results. Have an excellent local and excellent distant control. And such kind of patients, I think, should not be subjected to chemotherapy. That is what the point from this trial is. The second set of trial is a German trial, which also analyzed multiple questions. But one of the questions which also addressed in this was to include a node positive population, because the Taylor X trial did not include a node positive population, and node positivity has always been considered as synonymous with chemotherapy. But there has been a recent change in thought process that the biology of disease may be more important than anatomy of the disease. So they also included few lymph node positive patients, but they had to be an extremely low risk according to the genomic profiling. So clinically high risk, but genomically saying you are not right. And after doing a lot of analysis, the analysis is not yet complete, and they could actually tell that in those patients, even if it is node positive, that is N0 to N1, which means, as Dr. Devsa was telling us, up to 3 node positive. If you have a patient who has an extremely low risk, which is the top yellow, and then green, which is middle risk, these patients, even if they have node positivity, can easily be segregated by these tests. And with such an excellent result, you cannot add anything with chemotherapy, suggesting that a subset of a node positive population by gene analysis can possibly be spared of chemotherapy. There are many prospective trials going on, hopefully, which will answer this question. I think we'll come to the second type of test, and to my mind, this is the test which has actually revolutionized in a way of thinking, whether we are going to use it, whether we are not going to use it, are we financially placed in the situation, do we have that kind of population set like the kind of populations that they have, we can think of it or not. But if you have a patient like that, I think this is an excellent data. So this is a microarray test for node negative, as the MINDEC trial, a line below that shows node negative and node positive up to 3 node disease. So it is actually challenging the basic paradigm that node positivity should not be the only criteria, and you should actually assess the biology of the disease rather than just the minimal local spread of the disease to treat the patient. So the patient, this is an important slide set. So you could see that one in the light, one in the green here is a set of patients whom the physician thought low risk. They underwent a gene expression test. They also said low risk. So everything is fine. These are concordant, and there's no need to give any chemotherapy, so they go to no chemotherapy. On the extreme right is a red color, where the clinician felt that the risk of disease coming back is high, and even the genomic profile said risk is very high. Fine, that's okay. They go to chemotherapy. But the problem is in between, when the clinician thought low and a genomic test thought high, or the otherwise round, the clinician thought high risk and the genomic result said low. What do we do? Because there's a disconcordance. So they were randomized to either chemotherapy or no chemotherapy. And this is, what are they trying to do? So what they're trying to do is, if we were to trust clinicians alone, so the one on the left hand side, lower down, the clinical strategy, if was to be followed, would treat 50% of patients. Whereas if you were to follow, it's a complicated thing, but we can go back to that. But if you were to follow a genomic strategy, you would treat less than 14%, about 14% less patients. So saying so, that if you were to do genomic testing in a selected population of patients, possibly you're going to treat less patients. And it shows the answer here. What it shows on the left hand side is, if the clinician thinks the risk is high, but the genomic profile report says no, it does not benefit to add chemotherapy. On the right hand side is, if the clinician thinks the risk is low, genomic profile says no, the risk is high, it still does not benefit chemotherapy. So it says, if the clinician thinks risk is low, or if the genomic profile says the risk is low, there is no point doing chemotherapy. So what you can avoid is now giving chemotherapy to whom you have thought to give chemotherapy, and genomic profile says no, you can spare more patients from chemotherapy. And the only patient in which the chemotherapy needs to be given is if you want to give it, if the clinical risk is high, and if you would like to do a genomic risk, then and genomic risk is high. There are other tests. For the sake of completion's sake, we will touch on that. There is ProSigna, which is based on PAM50, one which was used to identify luminal A, luminal B, which was very nicely alluded by Dr. Datta. It also incorporates some clinical features like tumor size, is able to split the patients into good, bad, intermediate kind of risk. But one has to understand that at this point of time, as one of the major parameters for analyzing the validity of a test is, it has to have a prospective trial for that, and it does not have a prospective trial for that. So at this point of time, although we have a retrospective review of multiple prospective trial, for example, this is Austrian trial. In a retrospective review, it can identify who is going to do good, who is going to do bad. Then there is another trial called Dutch trial. Again, a retrospective review of a prospective case series, suggesting that these new entrants can also possibly play a role. But I think the most important is we wait for any prospective data set, as we have to a certain degree with Oncotype DX, and we have a level 1 evidence with MammaPrint. If you were to do that, this is a valuable item. So the last test to talk about is EndoPredict, and I think the only thing to take away from EndoPredict test is, one, it is a me too kind of a test. We are also there in the market, but I think the only thing it adds on to it is, I think that at the end of the day, the answer will come not only from that. What EP people are doing is they're adding clinical features like tumor size, nodal status, grade, so they're making a mix and match of genomic analysis and what we have been doing so far, the NNM and a grade, and I think they're trying to combine all the two together and come out with the result. And I personally believe that this is what is going to be the answer. You have to identify the stage of the patient, the category, as we can see on a pathology, add a genomic profiling, and I think that will answer the problem. Just to finish it off, they have been able to do something from Austrian data set, able to identify from other data set, but I think they likely represents what others have been saying. I conclude that biology is not limited by anatomy, but I would also add anatomy cannot be forgotten. It's a combination of biology and anatomy, which to my mind is the most important thing. So stage, pathology, grade, this cannot be ignored. There is a lot of disconcordance among a lot of gene tests. At least 2 tests like Oncotype DX and MammaPrint has been able to move a bit forward. You have to see in your practice whether financially and the kind of patient that they took, do you have it or not. If you use that, and if you have a low risk patient, you can easily avoid chemotherapy. I don't think chemotherapy can add anything to 96 or 97% result. And it can become a standard of care, maybe not in our country for all wholesome thing, but at least in West it is becoming a standard of care. A select population in our practice can be subjected to them, provided they can pay financially. Thank you.